Good morning.
Good
My
morning,
dear
sir.
colleagues, friends, ladies and gentlemen. I'm greatly delighted to welcome you to the this FCA activity. FCA is Forum of Cardiac Anesthesiologists of Bangalore, which is also the IACTA chapter of Bangalore. I welcome you to this. We would like to welcome you back after the major event, which was rated to be good, rated to be excellent and successful. Thank you for your help in that. And today we have Dr. Rahul Biswas from Calcutta to be with us for the next 1 hour or so. And to carry on the session, I request Dr. Keshamurthy to proceed with the session.
Thank you, sir. Good morning, all, and welcome to the breakfast session of TE teaching conducted effectively by NH Dr. Muralidhar, and welcome all for the morning session. And most happy to welcome Dr. Rahul G. Biswas from Narayana, Calcutta. So, welcome, sir. And today's topic is about physics of echocardiography, the most important thing, but very difficult to understand and implement it in practice. We just want a clear image at the end of the day on the screen to interpret it, but the amount of the physics and the amount of the ultrasound physiology, physics which has been behind that is most often forgotten. So I request Rahul to enlighten us and make it that we understand certain things which we keep cribbing about those things when the image is acquired, but we do not know at times how to solve the problem. So welcome, Rahul, and over to you. You are not audible, I think. Just share your screen and unmute yourself. Yeah, now you are audible.
Yeah, so thank you so much for the kind introduction, Dr. Murthy, and always my heartiest thanks goes to Dr. Muralidhar for organizing such excellent sessions on perioperative echocardiography. So I'll start sharing my screen. Just give me a moment.
Yeah.
Is the presentation visible?
Yes, we are. Yeah, first slide is visible. Thank you.
Thank you so much. Okay, then I will start the presentation, Dr. Murthy.
Yes, please.
Thank you so much. Okay. So welcome all to the breakfast session, and it is said that there are a few topics in perioperative echocardiography which can immediately put you to sleep, and these are physics in echocardiography. The second one is hemodynamic calculations, and the third one is diastology. So I know about this thing, and I will try very hard to bring out the practical points in the relevant knowledge of physics in echocardiography. So we need to talk a bit about sound, because the fundamental understanding of perioperative echocardiography is understanding of acoustics. And as you know, that sound is basically a mechanical energy which propagates through space in cycles of compression and rarefaction. Now, if you look at this image, the alternate cycles form the waves of sound. So there is an immediate point of compression, which is shown as C, and then there is a zone of rarefaction, which is known as R, shown as R in this slide. And then again, the sound wave goes through space in alternate cycles of compression and rarefaction, forming the typical tress of the sound wave. Now, if we take two identical points in adjacent waves of sound, we can calculate the wavelength. But mark my word, it has to be the exact same point on two adjacent sound waves. So look at this diagram. You will see that we are measuring the wavelength at the R point of two consecutive waves, or the nadir of two consecutive waves. You can also do it at the zenith of two consecutive waves. For example, you can measure the distance between two adjacent C, or between identical points in the upslope or the downslope of the curve. The take home message is it has to be identical. And then you get the wavelength of the sound. Now, there are immense practical applications of the wavelength of a particular sound wave. I mean, the higher the wavelength of a particular sound wave, the longer it will travel into the tissue. But the flip side is that the image resolution will suffer. So better image resolutions are with short waves. If you want to go to a deep part of the tissue for interrogation, we prefer longer waves. Now, the opposite or the inverse of the wavelength is the frequency of the sound wave. We as echocardiographers concentrate more on the frequency, because when you select a particular echo probe, you will usually not find the wavelength written there, you will find the frequency written there. So frequency is the inverse of the wavelength of the particular sound wave, and they're connected by the a constant. Now, what about frequency? The frequency, the higher the frequency it is, better is the image resolution, but higher the frequency of a particular wave, sound wave, the shorter it travels through the tissue. This has again very important practical implications. For example, you are doing echocardiography in a child, and obviously you will be having tissues at much lesser depth than an adult. So you tend to select probes with shorter frequencies, because you will get better resolution, you will get crystal clear image, and you don't need the sound wave to travel very deep, because the chest of a neonate or an infant is only of a small length, and smaller frequency is perfectly going to give you the results with a very sharp picture quality. But when you come to adults, you have put the probe. For example, you are doing a transesophageal echocardiography, you have put the probe in the esophagus. Uh, because of the length the sound wave has to travel to go to the anterior part of the chest. For example, the pulmonary valve, which is the anterior most part structure, you need a particular frequency which will travel more, but that is at the cost of the image resolution. Now, so this is about sound, but we are talking about ultrasound. What is ultrasound? Ultrasound is any sound wave which has a frequency more than the human audible range. And what is the human audible range? The human audible range, as we remember from our school days, is 20 to 20,000 hertz. Hertz means cycle per second. So any sound wave with a frequency more than 20,000 hertz is in medical literature called ultrasound, and all the application of sound in medicine is based on ultrasound. Now, in medical ultrasound, we are not even talking about hertz, we are talking about megahertz. 1 megahertz is about 1000 times a hertz. And you will be seeing that in the pediatric probes, it will be in the lower range of the megahertz, somewhere around 2 to 3 megahertz. Whereas as you go higher, you will find in the adults that the frequency is more, right? So that is there. Now, we have to know a bit about, we all use our transthoracic probes, we all use our transesophageal probes. We need to know what is there behind that orange colored dot that you see at the tip of the ultrasound probe. The heart of ultrasound probe is something called a piezoelectric crystal. And what is a piezoelectric crystal? It is a particular type of a crystal which, when stimulated by electricity, releases sound waves. And when it is hit by reflected sound waves, it again pulsates to generate electrical energy. So it is a transducer. The definition of transducer in physics is a device which can convert one form of energy to another form. And piezoelectric crystal is a transducer. Why? Because it can convert an incoming electric signal into a sound wave. And then when that sound wave comes back from the tissue, reflected back from the tissue, it transforms it again into an electrical wave, which is then calculated by the modern computation of the ultrasound machine, and it shows you as data in the monitor. Now, these piezoelectric crystals in modern echocardiography probes are put in multiple ways. So, in the beginning years of echocardiography, there used to be linear array probes. So, there were one or two piezoelectric crystals, very simple machines. You had to move the transducer to face a particular region, a particular field of interrogation. The breakthrough in medical ultrasound came with the phased array, where the piezoelectric crystals are placed in such a way that we can command them to trigger signals in particular sequences. So that is why when you move the multiplane probe from 0 to 180 degree, this phased array piezoelectric crystals can exactly send out sound waves according to the area that where you want to focus. So it is a marvelous modern technology. And then when we come to the 3D echo, we have gone one step further. We have the matrix array of piezoelectric crystals. So when you just look at that probe, and if you are lucky enough to probably play with a broken probe, you can go inside and see the structure. It is absolutely a marvel of modern technology which helps us in day-to-day diagnosis. So that is a bit about the probe. Now, this part is very important for us to understand. What happens when a piezoelectric crystal goes out to the human tissue? Now, we are interested basically with getting back most of that sound wave back to the transducer as a reflection. And whether the sound wave will nicely get reflected like in a mirror, excellent mirror, whether it will get reflected or not depends on something called a acoustic impedance. So based on the acoustic impedance, if a desirable difference in the density from where the sound is going to which tissue the sound is hitting is there, we will get a nice kind of a reflection, and we will see all the structures in our field of interest. But sometimes, based on tissue characteristics and tissue density, just as you have read in your school physics, we might have a bit of a refraction also. And this refraction is nothing but basically deflection of the sound wave, not coming back in straight lines the way it had hit the particular surface, but going in a different direction. Now, these refracted sound waves do often come back and hit the particular tissue interface again and lead to a lot of artifacts, imaging artifacts. So you have this particular side lobe artifacts, and that is why we need to know that which is the correct image and which is the artifact image, and that is where our understanding of refraction comes in. Now, scattering is another kind of a tissue, another kind of a event that happens when the sound wave travels through tissue. Uh, for example, if the lateral distance of the tissue which the sound wave hits is less than one wavelength of the sound, there is a big possibility that the sound will not get reflected, it will get scattered. Now, scattering is basically the sound wave going around in all directions, as you can see in that image. But it is not without, we have its use in medical ultrasound. For example, our entire concept of Doppler echocardiography is based on scattering of the sound wave on fast moving red blood cells. Red blood cells are very small structures. They can't reflect the sound wave nicely. What they will do is they will scatter that sound wave. And based on the coming back of those scattered sound waves, we apply the Doppler principle, the Doppler equation, and we try to guess the velocity of a particular moving blood in a particular area of interest. And the final thing that you need to know is called attenuation. Yes, sound is an energy, and the tissue will absorb a part of it. It will get converted into heat. Now, that depends on how much the sound will travel before getting absorbed. As I told you, again depends on the wavelength of the sound, or inversely, depending on the lower frequencies. Higher the wavelength, lower the frequency. So if you want the sound to travel a lot in the tissue without getting absorbed by the tissue as heat, use lower frequencies and higher probes, higher wavelengths. So that is a bit about the physics of the sound, the acoustic physics. We will come back to our day-to-day practice, which is called nomology. And as you can see, there are several kinds of buttons on the echo machine, on the interface, user interface. I will not speak on all of them because cardiac ultrasound, which we are discussing about, uses only a part of these buttons. It doesn't use all of them. Vascular ultrasonographers will use a different kind of machine interface. The ultrasound machine remains the same. So we will talk about what are the particular kind of buttons that we use for our day-to-day cardiac ultrasound. Now, the commonest button that you will press during, I'm sorry, there is some feedback. Okay. So the commonest button that you will be using, or the application that you will be using in day-to-day echocardiography, is called a 2D, a two-dimensional echocardiography. Now, you can see on the screen that there are about 8 to 10 rows which are lighting up on the left side of your screen. And these are the phased array that we are speaking about. See, those are the piezoelectric crystals. One by one, they are firing up and sending sound wave through the transducer into the tissue of interest that you are seeing. Now, this sound, one by one, it is going into the tissue and it is coming back reflected into the ultrasound. 2D is an amazingly useful application because it will map on your ultrasound screen as a dot. It will map a particular area of the tissue as a dot exactly based on the time as it is coming back from the tissue, and the brightness of the dot will depend on the energy with which the sound wave has come back. For example, if the sound has not been reflected, it has passed on, for example, through air, so you will get basically no reflection there. It will be dark. And For example, you have a nice specular reflector, a mirror. You will get a bright dot coming from that particular area, and you will identify it as tissue or bone or fat, that kind of a thing. So 2D
Sorry,
echo.
Rahul, sorry to interrupt. That screen just showing 2D echocardiography. Side there is only blank white color is
Oh,
appearing.
is it?
Yeah,
Uh,
I
okay,
don't know
okay,
if
fine.
others are seeing the image.
It's a graphic. I don't know. Could be a broadband issue or something. It's a
Okay,
graphic which is not coming, but I'm explaining
okay,
it anyway.
okay, okay,
I'm
okay.
explaining it.
Sorry. Right.
Sorry about that. So
I can see
yes,
the picture. I can see the picture. The
it might
blue
be a
picture
broadband
with
issue,
the
sir.
black on the left and red circle on
Yes,
the
yes,
right
sir.
side. Yeah,
Yes,
yeah,
sir.
I can see that.
Exactly, exactly.
It's a due to network congestion, sir.
Okay, okay.
Yes, sir.
Okay. So 2D echocardiography is a wonderful application because it shows us the heart and the vascular structures exactly as they are. It is like an image created from the actual structural anatomy. We use it very often. But the problem with 2D echocardiography is, if you look at that image on the right, the transducers, the piezoelectric crystals, are firing one after the other, and then it is waiting for that sound wave to come back. So it takes a bit of a time to map that particular cardiac structure. For example, you are looking at a high velocity area, for example, a vegetation on the aortic valve, which is moving very fast because it's a high pressure area. 2D echocardiography is not going to show you that motion of that particular vegetation because 2D takes time to construct that image. And that is where we use something called a M mode echocardiography. Now, M mode is a very brilliant, simple idea. I'm not using all the piezoelectric crystals. I'm only using one. And I'm focusing only on one area. I'm asking the piezoelectric crystal, you keep on firing on that particular area, very quickly get back the image and tell me what it is showing. So because I'm using only one crystal, my pulse repetition is very high and it can adequately trace the movement of a fast moving structure. So remember, for your practice, whenever you are interrogating a particular structure which has a high velocity, 2D will not be sometimes not be adequate to show that structure. You have to use something called a M mode echocardiography. M mode does have other particular uses. It is used for measuring the LV functions, both. So it has got multiple other applications as well, other than measuring high velocity structures. Now we come to the crux of the matter. I always tell my students that there is a lot of theory, but at the heart of the day, what my teachers used to teach was that a good echocardiographer knows how to get a crystal clear image. And getting a crystal clear image is the fundamental skill that one needs to learn to be a master perioperative echocardiographer. Even when you go to become a 3D echocardiographer, unless you have a very good 2D image, the reconstruction will not be optimal. So image optimization is very important. And that is where I keep on saying that there is something called a field of view. For example, when you are interrogating a particular area of the heart, we need to have the optimal interrogation box so that I am not using more than necessary piezoelectric crystals and my sound wave does not have to travel to unnecessary distances which I am not interrogating, tissues which I am not interested in, so that I can get my reflected sound waves faster and get a crystal clear image. The interrogation box has to be optimal and reduced only to the area that you want to see. Now, zoom, all of us nowadays, we use SLR cameras. Most of us are photography enthusiasts. We know there are two types of zooms. There is optical zoom and there is the electronic post-processing zoom. Remember that most of the echocardiography machines, the zoom function is a post-processing function, which means after the image is acquired, it just for all the pixels, for all the reflected dots the echocardiography machine has acquired, it just enlarges them. It doesn't do anything more. So there is still a chance of that photograph of that image getting distorted. But many of the modern high-end echocardiography machine has a pre-processing zoom where it can actually go deeper into that particular structure and get a bigger view of that particular structure. So in all practical purposes, zoom is only a post-processing function. Power is very important. Always use the optimal power. This is sound energy, remember. And you have put your probe either on the chest or within the esophagus, especially if it is a child. The kind of energy that you are sending through human tissue might cause it to overheat and might cause injury in vulnerable patients. So do not use the echocardiography probe when your interrogation is over. You can put it, you can shut it down, and always use power just to the level required for you to see the image clearly. Again, the depth is very important. You shouldn't be sending your sound waves to depths which are not required for your interrogation, because the higher depth you select, once again, remember the sound wave will need more time to come back, and that will reduce the image resolution. Optimal depth. Sector width I have also talked about. Try to use the gain function, which is nothing but the brightness function. Again, for example, I'll show you images later. When you increase the gain button, the certain parts of the tissue of interest, more power will be optimized there, and you will see it better. Now, let me give you certain examples. So I'm showing you very simple images because our concentration is on the nobology, not on the comprehensive assessment or the examination of the heart. So this is a 4-chamber. This is an ordinary 4-chamber, and next day when you are doing an echocardiography, instead of focusing on the structure, we all need to go back and see on the left hand side of the screen that what is the particular parameters that are being shown on the monitor when we are doing the interrogation. So right above is something called TEE lattice. These are called configurations. So what often echocardiographers will do is, for example, if he's an adult echocardiographer or a pediatric echocardiographer, they will put some settings, predetermined settings, that this will be the frequency, this will be the gain, and in your machine, you can put a name to it. For example, you can call TE adult, TE pediatrics, TE artics, whatever. You can put a name to it. The next one shows what megahertz is what is the kind of probe that you are using. So the Omni probe is a Philips probe, and it can go from up to 4 to 8 megahertz. That is the particular configuration of the probe. Now see, we are seeing the frequency. What frequency is being used? That's about 36 megahertz, 36 hertz, not megahertz. 36 hertz is the frequency of the sound wave being emitted by this particular transducer for the interrogation of this particular tissue. And I am interrogating the heart at a distance of 12 centimeters. Now, if this is a 2D image, because I am seeing all the cardiac structure, and it is written 2D, the gain is 50, and then and then is the decibel or the power. It shows that my power for that particular probe is 232. Now, this is where we are using something called gain. Uh, this is aortic valve, mid-esophageal aortic valve short axis view. And if you look at the left-hand side of the probe, you will see that I am not seeing the 3 leaflets of the aortic valve properly. The non-left and the right coronary cusps I am not seeing. So all I am doing is, on the left hand side, my gain is 20. Everything remaining the same, I have just increased the gain of my probe, which is a button on the interface. And now see, I can clearly see the non-left and the right coronary cusp. That is knowing knobology, and that is knowing how to use the buttons on the interface to optimize your image. So that is a practical application of gain. Always keep your gain optimal. Now, here what is being done is something called a lateral gain compensation. We are now in the stomach. This is a transgastric view, and I am not seeing the septum of the LV. It looks like it is a basal short axis LV. I can see parts of the mitral valve. I can't see the septum properly. So I am using something called a lateral gain compensation, where the intensity of the image can move from right to left of the screen. It is not about the depth. It is about the lateral resolution of the image. So simply, now if you look at both the images, you will see everything is the same. My power is the same, my gain is 41, the frequency of the sound wave I am sending is the same, but I am not seeing my septum properly, because I need to see, for example, a regional wall motion abnormality. So I optimize the lateral gain compensation, and the transducers, the piezoelectric crystals at that particular part at the septum, just increase their power and give you a better image. So that's lateral gain compensation. And this is something called a time gain compensation. Again, it is a 4-chamber, but I cannot see the lateral tricuspid annulus well. What was happening was, my sound wave is not coming with the proper energy and intensity to that particular depth. Okay, so there is a button called a time gain compensation, and as I increase it, the intensity at that particular depth will be increased. And now, after changing the time gain compensation, you can see that the lateral annulus of the tricuspid valve is clearly seen, so that you can do a tap C, you can do those additional things you can be doing. So coming to the various modalities, we have talked about the M mode or the I-speak view, the 2D mode or the brightness view, and obviously we will now be coming to the important contribution of Hans Christian Doppler, which is Doppler echocardiography. Now, Doppler had done the entire work on astral objects, moving stars, but medical investigators found that principle to be working very well in fast moving tissues like red blood cells. Now, the fundamental concept is that when a sound comes towards a particular object, the frequency increases, and when the sound moves away from a particular object, the frequency decreases. Now, that is one thing, and that is why when an ambulance approaches a stationary observer, the pitch of the sound keeps on increasing to a very high frequency, high pitch, and then as it goes away from the standing observer, it changes the character of the sound. Everybody notices it with the ambulance, with the moving train. Doppler physics is around us everywhere in the world. Now, in echocardiography, this observer and the moving object just changes. Here, the observer is moving and the sound emitter is stationary. The sound emitter is my piezoelectric crystal, but the observer is moving away or towards the transducer. For example, your transducer probe is in the esophagus and you have a mitral regurgitation. So during systole, a part of the blood is moving from the LV back to the LA or towards the transducer, or the RBCs are moving towards the transducer. And in other cases, the RBCs are moving away from the transducer. As you can understand, the frequency of the sound that we are getting from that particular RBC getting back. And remember, these are scattered sound waves because RBC are small structures, can be used by the Doppler equation to measure the velocity at that particular area of the RBCs. and it has immense applications in quantifying stenotic lesions, regurgitated lesions. We know all the practical implications of Doppler equation. Only one thing I will want to tell you, if the audience kindly looks at the Doppler equation, we can see that there is a cos component there. That cos is basically the angle at which the sound wave is impinging on the moving object. Now, in vascular echocardiography, we can change the angle button in the echocardiography machine interface to align it with the moving blood. But please, we need to understand that in cardiac ultrasound, changing the angle is not allowed, purely because the results that we will get will not be validated and the Doppler equation will not be applicable in that particular case. Now, we have to ensure that the sound wave that we are transmitting are hitting the RBC absolutely perpendicularly. Sometimes it is not possible. Sometimes there might be a little bit of angle. All we need to understand that this angle cannot be more than 20 degrees. The angle of incidence on the moving object of the sound wave cannot be more than 20 degrees. That more than that creates a major difference in the value obtained, and up to 20 degrees there is a variation of about 6% from the actual value of the velocity. So please remember that angle correction is not allowed in cardiac ultrasound. Now, in Doppler, there are a few kinds of Doppler. We have continuous wave Dopplers, we have pulse wave Dopplers, we have tissue Dopplers, and we have color Dopplers. So first, let us come to continuous wave Dopplers. Now, there is something called a pulse repetition frequency. What is pulse repetition frequency? It is basically the time taken by the sound wave to come back, to be sent from the piezoelectric crystal, reach a particular depth of the tissue, get reflected, and come back. Now, the problem is that if we are looking at fast moving structures, we don't have enough time for sending out a sound wave and then waiting for that sound wave to come back, because by that time that moving structure has gone to far greater distances. So our pulse repetition frequency for fast moving structures or high velocity areas are dealt with an application called continuous wave Doppler. What we do here is basically we use two transducers. One transducer keeps on sending sound waves. They are the messengers, they are the transmitters, and the other set of piezoelectric crystals, they only receive. They are not sending out something, they are not waiting for anything to come back. They are just receiving. So as a result, what we can achieve with continuous wave Doppler is that we can measure very high velocities in particular areas. But the problem is, since my piezoelectric crystal does not know from which particular depth of the tissue the sound is coming back, because remember, my transmitter and receiver are not the same piezoelectric crystals, there is something called a range ambiguity. So I can tell that yes, there is a very high grade stenosis or turbulence in the aortic valve area, but I really cannot say that whether this turbulence or high velocity is coming from the LVOT or actually through the aortic valve or the supravalvular area. That is something which can only be told by the pulse wave Doppler, but not by the continuous wave Doppler. Now, pulse wave Doppler is a simpler application. Here, only one piezoelectric crystal is asked to send out a wave and wait for the signal to come back reflected from the tissue. So it can tell from where a particular velocity signal data is coming. But again, because it takes a lot of time for this thing to come back, you won't be able to get or interrogate very high velocities. The advantage is that there is no range ambiguity. We can tell where that particular high velocity is exactly located. And that is where we, again, there is something which I have even seen in cardiologists. They do not look at the Nyquist limit. There are particular frequencies which are specified for interrogating. Whenever we read a echocardiography textbook, it is written that mitral valve interrogation has to be done at 50 to 60 Nyquist limit. Tricuspid valve also has the same thing. But the important thing is that we are not using the Nyquist limit properly. So what is the Nyquist limit? The Nyquist limit is that if a particular velocity of an object is more than the pulse repetition frequency, then there is a something called a aliasing which happens. So the frequency at which the piezoelectric crystal is sending out the sound wave, if the object of interrogation has a much higher velocity, we will have something called a aliasing. What is aliasing? Aliasing is basically the complete misrepresentation of the velocity data and the direction of movement. For example, if the RBC is moving away from the transducer and we are not using the correct frequency of the piezoelectric crystal, the aliasing will show erroneously that the RBC is moving in the opposite direction. And whereas it is actually moving away from the transducer, it will be seen as moving towards the transducer. And we will have a completely wrong interpretation of the particular direction and velocity of the Doppler movement of the RBC. So how can we prevent aliasing? Aliasing can be prevented by, first of all, and this is the fundamental concept that has to be carried by all echocardiographers, the area of interrogation has to be as small as possible so that the sound wave does not have to travel more than needed distance or depth into the tissue, and it has adequate time to come back to the transducer and give us the correct direction and velocity. So reduce the field of view or the area of interrogation. And the other thing is, if the baseline, when we are doing a spectral Doppler, if the baseline is in the mid part, sometimes the tip of the spectral wave will be cut off because of the aliasing. A simple thing can correct this. If we can just reduce the lower the baseline, then the entire spectral wave, or make the baseline higher in case of velocity below the baseline, then we can see the entire spectral trace in entirety and there will be no cutoff. So take home message is, use the most optimal field of view and always remember to adhere to the Nyquist limit. And there is a button where we can select the Nyquist limit to interrogate particular areas. Coming to color flow Dopplers, color flow Doppler is essentially application, a derived application. We basically put color based on direction and velocity of RBCs, which is already measured by my pulse wave and continuous wave Doppler. It is called Bert, as in Bert Simpson. So blue is away from the transducer and red is towards the transducer. Any RBC moving towards the transducer, which we can see and calculate from the Doppler equation, will be given a color of red, and any RBC moving away from the transducer will be given a color of blue. Now again, on the velocity color scale, the higher velocities will be given green, yellow and such colors, so that we can understand areas of turbulence and very high velocities in a particular area. So that is color Doppler. And finally, I want to say that the Doppler equation for a long time has moved away from calculating not only red blood cells. Now we use Doppler principle also for movement of tissue. Obviously, tissue movement will be of a much lower scale when compared to fast moving red blood cells. So the application is called tissue Doppler, and it has immense applications in measurement of the left ventricular systolic function. In left ventricular, the entire science of diastology is based on tissue Doppler echocardiography. We also do tissue Doppler for RV functions. The only important thing to remember here is that here we are measuring the movement of the tissue, for example, a septal annulus, myocardium, rather than the fast moving RBCs. So those are the principles of Doppler. Thank you so much. And I want to thank Dr. Shayandeep and Dr. Devika for also working with me in this presentation. Thank you so much.
Thank you, Rahul, for a wonderful, very clear presentation, which was even a first timer can understand very well how neatly it is useful in the echocardiography. I think chat box people are yet, it's a little like a hard channa to digest, so people might be still thinking of questions what can be asked. So just keep starting with the most of the times what happens is like if you have done in congenitals in tetralogy of fallow or in a severe aortic stenosis, when you try to calculate the gradient across the valve or through the across the pulmonary valve, you hardly get any gradient when it is very severe stenosis.
Yes, yes, very
Yeah,
true.
can you just enlighten on that if it is means if it is why it happens so? Is it
Yes.
is
I mean, I have, for example, that's a nice example you gave, Dr. Murthy. I mean, I have stopped measuring the gradient of the pulmonic across the pulmonic valve in tetralogies because in severe tetralogies, there's hardly any RBC, there's hardly any antigrade flow. And the entire concept of Doppler is based on catching a certain amount of fast moving RBCs and calculating the gradient. So
yes.
if a very cyanotic with a very less antigrade flow, we do try to measure the gradient, we won't have enough RBCs for the machine to calculate the gradient.
Correct.
So I only do it after the surgeon has repaired. I do a very minimal echo before this one.
Oh, very nice. Thank you for that. I usually with the residents keep giving an example of a door which is open for just 2-3 centimeters to a door which is open for around half a feet. A door which is open half a feet, at least sideways, you can push yourself. So there'll be some RBCs which are going with
Yes.
you when you don't have a severe stenosis. But when it is open only 2-3 centimeters, not even a cat can pass through that. So very few RBCs will be going. So it's difficult to calculate a gradient across that. I don't know what Murlidhar can correct me if I am wrong.
No, that's a very good analogy. That's a point which makes us understand the pathophysiology much better. Thank you for that point. Any other questions?
Dr. Sanjeevni Inamdar is for apical clot should be seen with TEE or TTE,
Okay.
transthoracic or transesophageal.
I would say transthoracic, because if we go through the AAC, American Society of Echocardiography, 17 segment interrogation of the regional wall motion, we know that the apex is the only structure which is much better seen in the transthoracic compared to transesophageal. For the rest 16 segments, transesophageal is just fine.
Okay. Thank you. I think, madam, your question is answered.
Good morning, sir.
Yeah, yes, Dr. Prabhu Shankar, come on.
Sir, what is the resolution and temporal? How to resolution, sir?
Yes. So thank you for the question, Dr. Prabhu. Resolution is what we basically simply means the crispness of the image, the clarity of the image. And it is an essential quality that echocardiographers should have to get the best possible resolution. And as I told in the beginning of the presentation, resolution depends on two particular characteristics of the sound wave. If the frequency is higher the frequency, better is the resolution, and lower the wavelength. We always have to remember that the frequency and the wavelength of the sound are inversely related. So higher the frequency, there is a better and crisper resolution, and lower the frequency, there is a there is a better resolution. So whenever we want a crystal clear image, you have to choose a transducer of the appropriate frequency. Otherwise, we won't get a good picture.
Okay. Thank you, sir. Thank you.
Thank you for that answer. So,
Close. But
where tissue harmonic should not be used. One person has asked. I can't see the name of the person who has asked the question.
Can you explain that question a little bit? I didn't understand that question.
Where tissue harmonic should not be used.
What is meant by harmonics here?
See, this is. Can I? Explain? Can I?
Please.
See, this whole system of echo nowadays is based on harmonic principle. That is, the delivery of the frequency may be different, but the receiving frequency is different. These are modern machines. Okay, these are not tissue harmonics. We all use tissue harmonics.
Yes.
But while previously we used to use fundamental frequency, where the delivery as well as the receiver frequency was it was at the same level. Okay, but when you are using tissue harmonic, that is the basic adjustment in the machine nowadays, you will see TH, tissue harmonics. You know, that is already set over there. But while calculating mitral wall area, if you use tissue harmonics, you will miscalculate the area because it gives higher resolution. So the calcification is also increased and the area calculation can go wrong. So here you have to bring that machine to fundamental level, fundamental frequency. Okay, and then measure the area.
Yes, ma'am. That is kind of self-explanatory because the entire calculation of valve areas is based on the Doppler principle and the Doppler shift. So if we artificially ensure that my transmitted frequency and the received frequency are the same, the Doppler shift will be entirely miscalculated and we will not get the adequate area. So that cannot be applicable in that area. Yes.
No, I agree. The harmonics helps us with higher resolution with fewer artifacts as compared to the traditional echocardiography. So this is being used for getting a better image quality on the screen.
Yes.
Can I ask Dr. Muralidhar Krishnamurthy?
Yes.
Can I ask one more?
Yes.
See, sometimes when to prevent aliasing, we do lower the baseline or high or make it higher. Okay, but sometimes it doesn't help. We have seen that. So in this case, it is better to shift to continuous wave Doppler. It happens many times that it doesn't help. It still has that capping effect. So it is better to go to continuous wave to measure that velocity, high velocity.
Yeah.
Yes.
Do you agree?
Yes. 100%. Because in pulse wave there is a range of velocity because of the same transmitter same crystal being used. So with certain velocities, it is absolutely mandatory to use continuous wave at the cost of the range and ambiguity, with us being blind to exactly where that particular high velocity or gradient is coming from. Yes, ma'am. Absolutely.
Yes. And can I discuss one more thing, which I am finding it many times that we do say that depth is important, but sometimes the images are better when the the structure is seen in a small diameter. Do you agree?
I mean the area of interrogation or the field of interrogation.
The depth. Depth, not area of intervention. I have not understood this, but the moment I reduce the heart size, it is seen better. This is the practical thing.
Yeah, obviously, probably the pulse repetition frequency improves and the image resolution gets better.
Another 3-4
good morning,
minutes are
sir.
left over. Yeah. Come on.
Good morning, sir. In the regurgitation, when we are seeing the mosaic pattern, how much is the color to be adjusted in the between the so that regurgitation is very clear.
No, you don't adjust the color scale. That is the principle of the color Doppler. On the right upper hand side of the screen, you will see the velocity color scale, and it will show you what colors represent which velocity. Now, above this color scale, whatever velocity is there will be assigned a different color. Now, that color setting is essentially done by the vendors, the echocardiography machine manufacturers. So it can be green, it can be yellow, it can be purple, whatever it is. All it shows is that it is a very high turbulent velocity, and the exact amount and the exact velocity cannot be measured by the echocardiography machine because of the particular pulse repetition frequency is not practical in this particular case. You just need to say that it is a very high velocity and it's a turbulent jet. That is all. We don't need to control anything here.
There's one more question.
Practically speaking, we usually keep it at 50 to 70 centimeters per second.
Yes, sir.
That is
60.
the velocity we keep it.
Yeah.
It's plus and minus.
Yes, sir. Yes, sir.
And that is for traditional, usual routine color Doppler. But if you want to see at low flows, you reduce the velocity to as much as 20 centimeters per second, especially if you want to see flows across ASD or very low velocity flows. There you reduce the color scale to about 20 centimeters per second. Otherwise, it's between 50 to 70 centimeter per second.
There's one more question. Are Nyquist higher and lower limits fixed for a particular machine? Can the Nyquist limit be discussed here? Just about how do you adjust the Nyquist limit, I suppose the question is.
Yeah. So no, that the Nyquist limit is essentially not machine based; it's structure based. So for a particular valve, we'll have a predefined Nyquist limit, and any standard echocardiography book will tell you that when you are using color Doppler, at what particular frequency will you interrogate that valve, which is, in other words, the Nyquist limit. Now, the Nyquist limit can be changed by changing the scale and the baseline. Both these applications are there on the machine, and by the interplay of these two buttons, you can bring it down. The more important thing is what I in my day-to-day practice is that most of the practitioners don't even look at that particular Nyquist level, and they are interrogating a mitral valve when it is 44, showing it is at 44. You need to bring it up to 50. Otherwise, what happens is that if it is too low, we might overestimate the entire regurgitation. So
Correct.
by the interplay of the button of the scale and the baseline, get it up to the number for every particular structure which is given in the echocardiography book, and then you do your color Doppler, do your assessment at that particular Nyquist level.
Yes.
Yeah, to simplistically saying, Nyquist limit represents the maximum Doppler shift frequency that can be correctly measured without leading to aliasing, and it usually equals to pulse repetition frequency divided by 2. And it is not fixed in a machine. Actually, it is operator can alter it. We can alter it depending upon the situation demands, as you correctly said. So this is an important component, especially in pulse wave Doppler, to exactly determine the speed, direction, velocity of flow, especially when it is low velocity flow.
Most important is if it is not set correctly, regurgitations can, if it is set low, regurgitation can be overestimated. And if you set it high, regurgitation can be less and underestimated. And this depends on whether you want to please the surgeon or irritate.
Color setting should be kept low for pulmonary veins and also ASD flow. So whenever the flow velocity is low, we would like to keep the color gain, the color settings for the color flow Doppler low. Otherwise,
Yes,
we
sir.
keep set 50 to 70 centimeters per second.
Yes, sir.
It means that whenever the flow is slow, low flow, there will keep on the lower side. Like
Yes. Color flow setting should be kept low for low flows.
okay.
Otherwise, it may miss it.
Okay.
Pulmonary veins are an excellent example because in general, as Sir says, it's almost always 50 to 70 for tricuspid mitral, the general valves we interrogate in day-to-day practice.
Yes.
But for
Yes,
pulmonary
sir.
vein interrogations, it has to be brought down to a lower level and we need to be careful about it. That's a very important point.
Yeah.
Do you change it for assessing the coronary flow when you want to demonstrate the coronary? Is it required?
I usually don't, sir. I mean, if the, for example, after a coronary bypass, if the surgeon has any issue with the flow, uh, I feel the only validated thing that I can tell the surgeon is probably go to the left main ostia and see if there's any turbulence. And the right coronary artery is extremely dicey when we can get it. Sometimes we don't get it.
Correct.
So primarily the flow parameter based devices that the surgeon themselves use on the epicardial arteries are better indicators than echocardiography for graft patency as far as we are concerned.
Yeah, as we are exceeding our time limits, I'll make two final comments. One is when we use the PISA, that is proximal isovelocity surface area, the color flow Doppler is used for this. And if you reduce the color flow velocity to 40 centimeters per second, then you can use the radius using a simplified PISA equation, that is r squared divided by 2, to get the effective regurgitant orifice area. This is a simplified version of the PISA. That is one comment I would like to make. And the second comment I would like to make is that now there is a technology called butterfly technology, where you can produce ultrasound not with piezoelectric crystals, but by using semiconductor chips. This is extensively being tested and experimented with in clinical situations, especially using handheld devices. This is showing considerable future. I mean, considerable, what is say, hope that this will become an affordable and cheaper version of the traditional piezoelectrical crystal based ultrasound generation. With this, I think final comments by Keshamurthy, and then we'll close it.
Thank you, sir. Thank you, Dr. Rahul. It was an excellent
Yes.
lecture and discussion. And but day to day, unless we apply it, we cannot suddenly go through or do these things routinely. Very nice. Thank you for having you on the panel for the talk. And thank you, sir, Dr. Murlidhar, for arranging the breakfast meets as usual from this week as a new batch of the speakers and new batch of topics. Thank you. Thank you all those who have attended.
Thank you, Rahul. Wonderful.
Thank you so much to all of you. Thank you, sir. Thank you, Dr.
Wonderful
Murthy.
presentation.
Thank you, Dr. Sanjivani.
Have a pleasant and great Sunday. Thank you.
Thank you. Thank you. Bye. Bye. Bye.
We will see you next Sunday. Thank you.
Bye. See you all next Sunday. Bye.